Hello, I'm Stephen Worthley, the Helpman Chair of Cardiovascular Medicine at the University of Adelaide and the Director of the Cardiac Catheterisation Laboratories at the Royal Adelaide Hospital in Australia. It's a real pleasure to be joined by Professor Prof Silber, Professor of Medicine at the University of Munich in Germany, and he also runs his cardiology practice there. Our discussion today is going to focus on new generation drug-eluting stents in patients with diabetes mellitus. Please note that this program will discuss investigational devices not approved by the US Food and Drug Administration and the off-label use of approved agents and devices. We're here at TCT 2011 in San Francisco, where we just learned some new data on drug-eluting stents in patients with diabetes mellitus. But first, let's briefly review some of the challenges that we face in treating this patient subset. Sigmund, I'd like to ask you a little issue around diabetes mellitus. How confident are we that this group is at increased risk? What evidence is there, and why are they at increased risk?
Well, we usually say that patients with diabetes have a sugar disease with elevated blood sugar. That's what's in the patient's mind. But in reality, I always say diabetes mellitus, type 2 especially, is not a sugar disease, it's a vessel disease, especially it's a disease of the coronary vessels, because that's what the ultimate fate is all about. So they have deteriorated endothelial dysfunction, which means the vessel function is not okay. They have impaired platelet function. We talk about sticky platelets, and the platelets are the evil of the coronary artery. Fortunately, we have prasugrel and ticagrelor today in patients with acute coronary syndromes to handle the problem of the sticky platelets. But the coagulation system is altered, and last but not least, and that's one of the worst parts, is they have an increased and excessive smooth muscle cell proliferation after stent implantation. So this is why with the old Bear stents, the restenosis rate in diabetics was extremely high.
And what clinical data have we seen in the sphere of coronary intervention that supports that increased cardiovascular risk in diabetics over non-diabetics?
Oh, there's a huge amount of data, and for the sake of time, I just refer to one of the studies presented here at the TCT. It was the 5 years follow-up of the Sirtax trial, called the Sirtax Late trial. And if you put together all the data and compare diabetics to non-diabetics, it showed that diabetics have a double number of major adverse cardiac events. So in non-diabetics, it was about 15% in 5 years, and in diabetics it was 30% in 5 years. That means that almost every third patient with diabetes after stent implantation has a major event, and this is a situation which of course has to be improved.
Yes. So higher MACE rates, but importantly ischemia-driven target lesion revascularization rates, and so as you mentioned, the drug-eluting stents have obviously been an advance. How confident are we that the second or new generation drug-eluting stents are an advance over first generation stents?
There is some data showing that the second generation stents are better than the first generation stents, but it's not really that clear. We have in part controversial data. For example, the Sirtax trial I just quoted to showed that the Cypher stent in diabetics is better than the Taxus. So this was first generation versus first generation. But on the other hand, we have this huge meta-analysis from Spirit trials, including the COMPARE trial, showing that in diabetics there was no difference between the Xience, a second generation stent, and the Taxus, which is a first generation stent. So the data are somewhat confusing.
Yes. And it's interesting to tease you out on those. The Sirtax trial was a comparison of the paclitaxel-eluting stent versus the sirolimus-eluting stent, Cypher, which suggested the Cypher stent had a halving of ischemia-driven target lesion revascularization rates. But there's this concern or issue raised about the potential role that paclitaxel may play from the data set that you mentioned, from the Spirit 2, 3, 4 and COMPARE, where there's been no difference over Xience, for example. So what data have we seen recently or presented at TCT that perhaps helps us to gain some more insights?
Well, to solve this controversial data, we need a randomized trial specifically addressed to diabetes. And so far, no study has been presented with diabetes as an inclusion criteria and a primary clinical endpoint. We have several studies with diabetes as an inclusion criteria, but all these studies had surrogate endpoint like weight loss or something like that, and geographic surrogate endpoints. So I'm very happy to have learned here at the meeting that in India a new trial has been launched. It's called the Tuxedo trial. And what they do is they have diabetes as an inclusion criteria, and what I like very much, they have a primary clinical endpoint. That's why they need over 1,800 patients. So I will be very, very happy to see the final solution from a prospective randomized trial with this primary clinical endpoint, which is target vessel failure.
Yes.
But until then, we have to wait.
Yes. You mentioned earlier about the SORT-OUT-4 trial and some data that's been presented here. Did you have any interesting insights from the diabetic group from SORT-OUT-4 that was presented?
Yeah, the SORT-OUT-4 showed a trend. It was not really significant. It showed a trend that the Xion stent is superior to the Cypher in diabetic patients.
Yes.
But again, it's a subgroup analysis, and to solve this, we need a trial like the Tuxedo, as I mentioned before.
You do. Although not presented at TCT, I think it's relevant to discuss the trial from Japan, from Dr. Kimura, called the RESET trial, although not yet published, as you know, that had a very high incidence of diabetes. About 45% of patients had diabetes in that study. I'm interested in your thoughts about some of the findings that they made in terms of the relationship of diabetes on Xience versus Cypher in that large study.
Yeah, in the RESET trial presented this year at the ESC, it was an interesting result. It showed that in insulin-dependent diabetics, the Xion stent was significantly superior to the Cypher stent. But the problem is that this was not a diabetic study. It was only 40% were diabetics. And if you look at all the diabetics, this difference was not significant. Only if you look at the insulin-dependent patients, this was significant. So we have a subgroup analysis of a subgroup analysis. So this is always difficult, and it may be only generating the hypothesis. But again, like in the Tuxedo trial, you have to have a randomized trial with strict inclusion criteria, diabetes, and a primary endpoint. So this is helpful, but it really doesn't solve the problem.
No. So tough. So for us in clinical practice right now, we've got evidence that certainly the second generation stents, Xience, is not inferior to the first generation stents, and some evidence that it could be superior, but perhaps we await further randomised controlled trials specifically addressing diabetes subgroups, and we'll await Tuxedo.
That's for sure. So why should you use a first generation drug-eluting stent if it is strictly not superior to the second generation?
It's a good question. Although certainly we have, whilst that's a concern that has been raised by the COMPARE and the SPIRIT data set, I guess when we look at that other body of evidence, although not definitive, it's built, hasn't it? It includes Surtax, showing Cypher better, but more recently SORT-OUT-4 and the RESET suggesting that there was a benefit of a new generation stent, the Xience stent, over first generation stents in those two examples, the Cypher stent.
Yeah, I agree.
That brings us to another question though. We've got more than one so-called second or new generation drug-eluting stent. Is there any evidence to show that there's any difference in how the new generation stents behave in diabetes, or are they comparable?
Well, this was the purpose of the Resolute all-comer randomized trials. We compared the Xience stent to the Resolute stent. So the Xience is the everolimus eluting stent, and the Resolute is the sotarolimous eluting stent, the new version of the Endeavor. It has the same substance, sotarolimous, like in the Endeavor, but a different and improved release kinetic. So this is why we prefer the Resolute of the Endeavor. So the overall results, we've published this in New England Journal of Medicine and recently in The Lancet. The overall results were that both stents are comparable, so no stent of these two is superior to the other. In the diabetic subgroup, we have presented the data here yesterday. We did something even on top of that. So far we have altogether 5 Resolute studies. The randomized trial I've mentioned with over 2,500 patients, but we have also registry trials. And the important thing is that the definitions of the events and so on were all the same. So this was prospectively global Resolute program putting all together. So altogether we have over 5,000 patients with about 30% of diabetics, which means that I've presented over 1,500 patients with diabetes. And interestingly, the bottom line was that there was no difference, no statistical difference between the Xience and the Resolute stent. For the Xience, we had a 1-year event rate of 9.6%, and for the Resolute of 7.8%. So this is not significant. So I think the conclusion is that in diabetic patients, there is no difference, at least between those two second-generation drug-eluting stents.
And pleasingly, really, they are very low MACE rate events in a high-risk group of diabetics. So they're pleasing results.
Yeah, the stent thrombosis rate, for example, was about 1% per year in both groups, in both stent groups. So I think 1% stent thrombosis rate is still, you would say, unacceptable. The optimal would be 0%, but I think in that sick patients, 1% is good. I mean, don't forget, in the older times, we had 3% stent thrombosis rate, and now we are down just below 1% in these high-risk patients.
Yes. You mentioned about early on about some of the mechanisms in diabetes and the coagulation cascade being accentuated and issues around platelet reactivity. I'm interested from that data set that you mentioned, the dual antiplatelet therapy use. Do you have any comments about how dual antiplatelet therapy, how long it was being used for, and in your clinical practice, do you change how you manage your diabetics with dual antiplatelet therapy versus your non-diabetics?
Well, that's one of my favorite topics, actually, because when we were writing the European guidelines for PCI 6 years ago, 2005, we have never seen data, convincing data that dual antiplatelet beyond 6 months is really important. This is why we have recommended at least 6 months, and we just repeated the same recommendation about a year ago in our new guidelines. On the other hand, in the United States, here everybody gives it at least 1 year, but we don't have data for at least 1 year. And the Prodigy trial, which was presented at the last ESC, showed that beyond 6 months there's no advantage of prolonging dual antiplatelet therapy. On the other hand, it's the opposite. You have just a higher risk of bleeding, especially GI bleeding. So we still go along with 6 months, not with 1 year. But in diabetics, we don't know. You know, people are just afraid of doing a shorter antiplatelet regimen in diabetics. But the question is, do we know? And the answer is no.
No. And it's interesting because Greg Stone presented some meta-analyses from the SPIRIT data confirming those results. Very low stent thrombosis rates beyond 6 months. But in patients that came off dual antiplatelet therapy, obviously quite a significantly increased stent thrombosis rates before 6 months. With the current second-generation stents in all comers, certainly I think we're reducing that window. But a number of us do still remain concerned about our diabetic patient population too.
I'm very happy that Greg Stone confirmed the European guidelines.
So I guess in summary, where does that leave us? Whilst we understand that diabetics are a higher risk group of patients for adverse outcomes after our stent procedures, we certainly have got good evidence that drug-eluting stents are a better option for them than bare metal stents. Although there's still this contention around paclitaxel stents, I think the body of evidence is certainly supporting that they have improved outcomes and the best outcomes with second or new generation stents. And certainly on some of the evidence that we've seen today, and some of it presented here at TCT by Sigmund, that our current new generation stents are probably as good as each other in treating this patient subset. So thank you very much for your time. And Sigmund, it's been a real pleasure to talk to you this afternoon.
Thank you.
All the best.